about the right-sided heart valves. So we're going to talk today about pulmonary valve, tricuspid valve, and then a few additional things that are kind of associated with those. So first of all, let's talk about pulmonary valve anatomy. So what do you know about the anatomy of the pulmonary valve?
Semilunar valve.
Semilunar valve, what does that mean? Shaped like the sun?
No, the moon.
Good, so it is semilunar. How many leaflets?
3.
How many cords and papillary muscles? Trick question, none. Good. Just checking. So its structure is kind of unique to that and the aortic valve. So the semilunar valves are shaped differently, as you've seen. So they're kind of cup-shaped as they go, and then the leaflets kind of come up. They form kind of a point in the middle. Each of those leaflets is fairly equally sized, so they're just not like a tricuspid valve where they're different sizes. And then it's kind of done by pressure and stuff like that. But these cups, they are significantly cupped. If you get to see a real valve, there's a pretty good pouch in there that kind of pushes it down. So that's just kind of the structure of it. The aortic and pulmonary valve, so which valve sits closest to the chest wall? Pulmonary, yes it does. So this is a good one. So if you take two arteries during fetal development, just think of your two arms here. You take your right arm and wrap it over. This is how the twist and the formation is of those tubes. So they start from one tube, and then they get a membrane that divvies down the middle of them, and that's kind of how it starts. So the aortic and the pulmonary valve are formed by the same structure, same tissue. And then they kind of divide out. Secondly, the pulmonary outflow, or the right ventricular outflow tract, that part of the ventricle is also formed by that same structure. That's why the ridges and stuff that are in there are the way they are. And then the ventricle grows up from the other direction. So I wish we could do a full course on just fetal development and embryology, but too bad. We don't have that. Down the road, maybe. It's something that I would like to add to the program is those couple things. But so 3 leaflets. It is a semilunar valve. It's the right ventricular outflow tract. So sometimes we'll call it, pulmonary valve. We'll talk about pulse waving it. If I ever talk about that, I'm actually talking about pulse waving the right ventricular outflow tract prior to the valve, and then through the valve itself, we'll use continuous wave Doppler always. So that's anatomy. What views do we see the pulmonary valve from?
Parasternal long axis.
Okay, so PLAX.
PSAX.
Okay, so both of those. What about apicals? I mean, theoretically you can get them, but that's not where we look at them. So pretty much everything that we do on Dopplering and evaluation of pulmonary valve is from parasternal view. You can actually do some pretty good evaluations also from the subcostal view, but which are going to be the same as the parasternal view. They're just going to be twisted a little bit differently. So what does that look like? Parasternal long axis. So this is tilted outward. Which direction do we tilt out? So our beam should be going up towards the left shoulder, so we're tilting up that way. What direction does the valve point? The valve tips. So they point down or they point up?
Down.
Because it's going out, right? So, yep. So that's one clue that it is pulmonary that you're looking at, because especially early on as we're scanning, it's easy to confuse the tricuspid with the pulmonary. And if you point the wrong direction, or you're thinking the cord rather than the beam, you'll go the wrong direction, have the wrong thing. So a clue is that we see that. Having said that, this is probably the hardest valve and the hardest structure that we look at from a parasternal perspective. And why is that? Because it's really close to my ribs, and my transducer is really close to there, and any kind of movement, I'm hitting ribs and stuff like that. So this thing's hiding right behind the ribs. It's actually easier to see structures that are a little bit further away from the ribs and deeper into the body, even though the depth is an issue at some point. So pulmonary valve can be tough to see. That's the long axis. Short axis looks like what?
The base.
It is the base. So we are looking at
Right atrium.
a pair of pants there. So right ventricle on top, tricuspid valve points up.
Mine never looks like that.
Something like that. What's that?
I said mine never looks like
It
that.
never looks like it. Of course not. I mean, if we do, if you struggle with it, you might lose that part of it, but these chambers we should definitely get. So we should have the right atria, left atria, right ventricle on top here. The outflow is on this side, the inflow is on this side. So tricuspid coming in, pulmonary going out. So we're talking about over here today. If I'm imaging this, how do you want to set up your transducer? Because I know that most of us, when we scan, our transducer is going to be up here. We've got this big sector like that. This one here, it's probably going to be up here. We're going to be like this. What do you want to do with your system to optimize that? Nothing. It's all window, right? Yes, narrow the sector size down would be very helpful. Regardless, if I'm in this image here, I'm going to get a whole ton of shadowing and stuff in the lung artifact way out here and over here. So why show that? We can minimize that and make it's going to be a more aesthetic, easier to look at type of an image if I can get rid of all that garbage. It's sort of like your point and click camera. You know, do I do it where I got all this stuff in the background, or do I kind of focus it in on stuff that's important? Same thing with this. So this one, you're pretty much just going to cut it off all the extra stuff there. So you do want to have the anatomical reference still. So I need to see some of the right ventricle. I still need to see the tube, obviously. I want to get it lined up so it's more straight up and down if I can, particularly when we do Doppler. We need to be able to see those jets in line with my line of sight. This one here, I might have a beautiful image and all this, but do I need to see all the right atrial free wall? No, I don't. So I can cut that down. And what's the advantage of bringing my sector size down?
Faster pulse repetition.
Okay, so yeah, it's going to affect the speed of my images, so that's going to especially when I stick color Doppler on, it's going to significantly affect my temporal resolution, the speed of it. And these are fast-moving structures, I need to be able to do this. So remember, in cardiac, we need to have at least 25 frames per second to be able to get a decent image. So my frame rates have to be high. If I've got a very low frame rate, I'm going to lose temporal resolution. I'm going to lose the possibility of sometimes even seeing some of the jets and things that are going on. So it's important that we narrow that down. Narrowing my 2D down also affects my Doppler. So if I narrow that down, I've got all my lines of sight packed in that area. It improves my frame rate significantly. Pulse repetition frequency, all that stuff. So try to get in the habit of kind of focusing on the area that you're interested in. My only caution to that is, and especially when we use Zoom, so this week's lab we're adding Zoom to stuff. You want to sector size down and put my depth appropriate before I go into Zoom, because if I take this big huge sector out here and I zoom in over in this little corner, it's still processing all that other stuff and it's still affecting your frame rate. So narrow it in. It will also give your tighter line density and stuff like that, so that you also get a better detail resolution. So that's important for all these, especially when we get into Doppler. And my 2D and my color going, when I put my spectral Doppler on, it will actually degrade my spectral Doppler if I have all that stuff big and open. So make sure to optimize that. Okay, M mode. So let's take now an M mode cursor, and so through this structure we're going to go through just one leaflet, because we're not going to be able to get across the leaflets like we do on an M mode of a mitral valve, because we don't see them in that plane. We only see it going directly into it. And again, people don't really do this nowadays, but when echoes originated, it was only M mode that we had. So they looked at all kinds of things and put the lines through them. So the line of sight is going to pass right through the leaflet. You could do it in the long axis also, but it goes right through that leaflet. And all you're going to see is that it's going to go over, there's going to be a bit of a blip there, it comes down, and then normally speaking I've got a little box and then it comes out like that. So that's what I see in my M mode. So there's a diagram on some of the slides that show the various states with that. The ones that I want you to know for sure is what it looks like in normal. Remember, we're only looking at a single leaflet. We're not looking at multiple leaflets. So it's kind of like a half a box, I guess. In a stenotic situation, it's going to look, oops.
Is that supposed to be upside down?
Yeah, in our slide, it shows the little bump is going as a
Oh,
downward
the downward?
reflection.
Okay, yeah, sorry, it's downward. See, I don't do this. Thank you. Okay, so downward, and then this one. So anytime a valve is stenosis, what's kind of the pathology behind a stenosis, do you think?
Dampening?
So, well, the movements and stuff are going to be restricted. So the idea of a stenosis is it's being held so that it's preventing blood flow from getting out, right? So in that process, often the valve leaflets get really thick. Okay, they might get calcifications on them. They just, it's what we call a myxomatous valve. Do I need to spell that?
Yep.
Probably.
And I apologize, I alternate often between caps and lowercase, so, sorry. I'm doing good if I don't do it in one word.
So that's when the valve thickens?
So yeah, myxomatous valve is a thickening valve. It's kind of the first stages of things going wrong. And it's not a severe thing, it's just that that's making a process towards that. And as people get older, that's kind of a natural process. But as it gets significantly thick, I'm going to get, your lines are going to be thicker. Okay, just because that valve is thicker. So it's going to look like a really thick, bright line. Sometimes you'll see some shadowing and stuff beyond it because of that. So in a stenotic valve, I'm going to see more of this. There's also going to be less movement. So honestly, it's not going to dip down as much as this. It's going to go down less. If I was looking at an aortic valve, it would be, instead of having the nice big box, it actually opens very, very little. So my box is very, very narrow. Okay. And then that's really the main ones to know. Yes?
And so on here it has like pulmonic stenosis. So is that just like another step down from the?
So this would be stenosis, just a really thickened valve.
It has like the first one like go way down.
Okay, yeah. So you're talking about this dip here goes down further.
Real big depth.
And I'm not really concerned about that stuff. Just know the thickness and stuff and what it's going to look like that way. Again, people nowadays, I have not seen anybody do an M mode on a pulmonary valve in years. So I just want you to know it because it could still end up on registry. It's still in the book, per se. All right, but honestly, it's unlikely that you'll see anybody doing it. Okay. So with stenosis, I may jump around here a little bit as we're going through, but in stenosis, that situation with the valve, we get what's called a doming. So what do I mean by that? So the opening is restricted, so that means the opening of the valve itself is smaller than it should be. And the pressure is coming from what side? It's coming from the right ventricle, right? So it's trying to push out, the valve is restricting it from going. So what happens if I've got this very narrow opening on this valve, I get this doming shape, okay? So this part is domed because what's happening is the pressure is pushing from behind the valve's not opening and letting it go freely, it's kind of holding it back. So that big pressure kind of pushes the leaflets out into a dome shape. So doming is common on all stenosis. If I'm looking at it in this view here, instead of opening, these leaflets would normally come out and just lay flat out like that, but in this case, that's beautiful, it domes like that, so it's curved. And that's because of the pressure behind the valve. All right, we're going to talk about Doppler and that stuff in just a minute. So any questions on the M mode other than that? So it's just a single line going through a single leaflet of that valve. Depending on what view you're looking at, and that's kind of the pattern that you're going to see, should we see that.
We don't measure anything there?
Nothing to measure, no. Good. All right, so pulsed wave and continuous wave. So let's talk about a normal pulmonary valve to start with. So we've got our baseline. So If I'm Dopplering from this perspective, flow's going away from me, which direction should my baseline be moving? So I should put it upward. The flow is going away from me, right? So it's going down. So I want my baseline near the top, and I should see during systole or diastole? Systole, yes.
I love that face.
So it's a systolic movement, right? So we're pushing the blood out the pulmonary artery and the aorta at the same time. So this is a systolic thing, so your QRS is going to be somewhere around there, just prior to it, okay? So it should be a roughly parabolic shaped waveform. Did we talk about this last time? I feel like we did. Maybe it's just the slides I was doing yesterday. Deja vu. So it's a mid-systolic peak, so it's parabolic, peaks in the middle, okay, on a normal pulmonary valve. Normal pulmonary valve velocity should be around 80 to 100 centimeters per second. Not that that's super critical, but again, I want you to kind of have an idea where to put your scale on this, because if I've got a scale of 200, that's going to significantly throw things off. So honestly, as we go through the protocol, the very, very first pulsed wave Doppler I do on the system is actually going to be the pulmonary artery on the right ventricular outflow tract. So this is actually RVOT. So this is a pulsed wave to start with. Sample gate is going to be just prior to the valve. Okay? So if I'm taking an area, just like I did the LVOT, this is going to be just the area just, a few millimeters in front of the valve itself. If I'm doing it in long axis, it's going to be there. If I'm doing it in short axis, it's going to be right here, just before the valve. Okay? That's my normal flow. If this is pulsed wave, I have an envelope. So you should see a nice envelope there. Okay? Round 80 to 100 centimeters per second. So velocities overall on the right, remember, are a little bit less than what it would be on the left. Okay, so my LVOT I would expect to be slightly higher than that, depending on the patient. All right, so that's pulsed wave Doppler. What do we measure on pulsed wave Doppler? We're going to measure what's called the acceleration time. So acceleration time, you're going to set your caliper, you're going to select the correct tool in the system. And each system has different tools for measurement, and I'll talk about those in a second. But basically I'm going from that to the definite peak here, okay? And the acceleration time is pretty much drawn like a line between that. Okay, so I'm looking at how fast it takes to get to the peak of that flow. So that's my pulmonary accel time. I just put accel time, it means acceleration time. T for time. Not Excel. Okay. Good. So we'll talk about what happens in abnormal situations like pulmonary hypertension and stuff like that. We talked about that a little bit before on the slides I did. When it becomes more abnormal and I've got more pressure that is going against in my pulmonary system, this pulmonary accel time gets less, so it gets to be a very steep slope. We'll get into what we call the flying W pattern. So in M mode, you'll see kind of the flying W pattern. So the box part is going to look more like this. And in the waveform is going to be a very steep upslope. So I get an early peak and then a little blip after that. Okay,
You
so
said normal pulmonary accel time was 80 to 100 meters per second?
this is
Centimeters?
milliseconds. So the accel time is measured in seconds. 80 to 100 is the velocity of that flow. So, but the acceleration time is actually measured in milliseconds.
But would it also be 80 to 100?
No, it's actually different than that. I don't have it right in front of me here.
Do we need to know it? Because if not, I don't care.
What's that?
I said, do we need to know it? Because if not, I don't care.
It would be good to know.
No, you don't need to.
Sorry, guys.
Yeah.
See it really well because it's really tiny on this slide. We can look at that. So, but it is in the text as well. It is helpful to know those numbers. I don't necessarily go by those numbers per se, other than to know that the general trend is that when it gets worse, it's steeper, it's faster. And I want to say it was less than 80 milliseconds, whereas normal's like over, I think, 130, something like that. Don't quote me on that. I'll have to look at what the book
Is it
says.
this right here?
Yeah, I believe
Yeah.
The
it's
pressure?
so. Yep.
130.
Yes.
Okay.
So.
It's
when
not
you say
pressure, it's
when it
time.
gets
Well, this one
worse,
says for
what are you
estimation
talking
of
about?
pulmonary pressure.
Yeah, it's estimating pulmonary. The pulmonary pressure is going to be a different measurement. The Excel time is what we're
Okay.
interested
So
in.
no, that's
But yeah,
okay.
When
sorry.
you said it gets worse,
It gets
do you
steeper when
mean
it gets
the-
worse.
Do you mean stenosis?
This is not stenosis. This is just pulmonary hypertension.
Okay.
So this is the force that it's pushing against. This is kind of like the afterload of the right ventricle. It's forcing against the pressure in the lungs.
Okay. The time.
Yeah. So when the pressure buildup is high beyond the heart, then that's when I'm going to have a decrease in acceleration time. This is not stenosis. Stenosis we'll talk about in just a sec. So this is called the flying W. So you'll see a flying W pattern in pulsed wave Doppler. You will also see it in the M mode. Those both show that W when I've got pulmonary hypertension. So if I haven't mentioned it already, it might be important, but if you see flying W, it's pulmonary hypertension is what you're looking at.
So when.
That may or may not be on the test, ever. All right, so flying W is important. And again, that's not a valve stenosis, that is hypertension, pulmonary hypertension. Is that clear now? I know it's early. All right, so what happens in a stenosis situation? So what happens in all stenosis situations with flow? So I'm in the maximum narrowing. What happens to my velocity? It drops significantly.
Increases.
It goes up, right? So, well, hold on, before I do this.
She already
It's
drew
already
it.
on my.
We're halfway there. When I get into stenosis, we're actually talking about inside the valve. So I want to make this clear first. This stuff is right ventricular outflow tract. This is pulsed wave in the right ventricular outflow tract. Not talking about stenosis yet. I use this to correlate to what the stenosis through the valve is. So that was the pulsed wave of that. So let's get rid of the accel time. So the acceleration time is what we measure on that. Pulsed wave, right ventricular outflow tract. Now let's talk about CW for the normal. Why would we use a pulsed wave in the RVOT and a CW through the valve?
Max velocity for.
Because we are going for max velocity. We want to get the highest velocity when we go through the valve because that should theoretically be the narrowest place in the flow pattern. So we do want to have really good windows. Make sure that you're going straight through the center of that in either one of those views that you're doing it from. But we're looking at the actual opening of the valve itself. Now normally the valve opens, but it's still the narrowest place of that valve. So CW is used to pick that up. It's going to look the same parabolic shape, but because we're using CW, what are we going to have different? So this had a nice enveloped window because it was pulsed wave, right? This is going to be the spectral broadening. This is going to be all filled in. That's also going to be what my continue wave looks like. So it's going to look, pulmonary valve flow is going to be parabolic. It's going to peak mid-valve. Let's get rid of this. Velocities here we expect to be higher than whatever the LVOT was. So my velocity might be just a bit higher. You might start out on a normal valve with the baseline around the same place. However, when I jump into CW, when I turn CW on, it has the settings of whatever I Dopplered last. Okay? The very first Doppler we do with CW is a tricuspid valve where we have a scale set at about 3 to 4 meters per second, or 3 to 400 centimeters per second. So it's high velocity. So when I jump into CW on this waveform's up around 100, maybe 120 centimeters per second. So that scale, if it's set at 3 to 400, it's going to be itty bitty little tiny waveforms. So make sure that you drop your scale on this. I'll be coming to this right from pulsed wave, and the pulsed wave is set differently. So just make sure to set that up, and that's just going to be the workflow.
So you're just directing your continuous wave straight through the valve, through
Yes.
the opening?
So you'll be the same area, but instead of having the gate, it's just going to go straight through the center of the valve. Okay, that's important. Your cursor may look differently with CW, because you guys haven't really used CW yet, right?
Mm-hmm.
Okay, so depending on the system, it might just be like a big dot. Generally speaking, from an engineering standpoint, CW doesn't really need, because it's not range specific, but the way that modern transducers work, they do recommend that you put that dot at about the area that you're interested in, even though it's not technically required. Because the beams are coming from a big crystal, not like the old pencil probes where it's just a single, they don't have any kind of focus, they just shoot. One fires, one reads, but in these they're using different crystals to fire and read depending on where that point is. So it's not range specific, but it's recommended you do put that on your area of interest. So this one goes right through the valve, but basically the same area, that line is going to go through the same area that the pulsed wave did. Waveform's going to look the same, the velocity is just going to be a bit higher on a normal valve. When the valve becomes stenotic and we get that doming, what do you expect to see on color when I see a stenotic area? What do you see on a carotid? So you see aliasing and, so you see flow convergence, right? So it's going to come down, it's going to alias, and I'm going to get a lot of, what's the aliasing caused from?
Turbulence.
Turbulence, right? So we're going to get a lot of turbulence after it. So when I stick color Doppler on, going out, I'm going to see a confluence of aliasing going out that direction. Now, being that these are going away from me, what color do you expect that to be? Blue. Okay, it's going to be blue primarily with aliasing intermixed with that. Okay, so your jet is going to be, it's not a jet per se, but it's, well, it kind of is. It's the flow convergence, it's going to get aliasing out there. So it's not abnormal to see that. I would expect to see that on the more stenosis. Stick continuous wave through it, I get this. This velocity is obviously going to be much, much higher when it's a stenotic valve. So it's going to look the same pattern, but now my velocities are going higher. What is a aortic, I guess we don't really talk about aortic stenosis. What do you think a stenosis would be? So this is, say, 120 centimeters per second on a normal valve. What do you think it would be in a severely stenotic valve?
300?
Yeah, it could be 200, 300, 400 centimeters per second. Okay, so they can get very, very high velocities. So obviously I'm going to change my scale to match whatever it is I'm looking at. In a stenotic valve, what do you expect your pulsed wave of the RVOT to look like? Same as it was before. So that's my, yeah, so like in a carotid, you would do like a proximal section of the CCA or something, or within 2 centimeters you do that normal section. Before that, it should be a normal-ish velocity. It might be affected slightly because it's running up against a wall. So the velocities might be slightly lower, but it should be similar to what it was before. And then you'll get that big jump in velocity through the valve. Okay, so that is stenosis. With what mode do we use?
CW.
CW.
So that's
Good.
what stenosis looks like.
Yeah, so it will look the same, just a higher velocity. So this could be like, I say,
200 to 300.
3 to 4 meters per second, or 3 to 400 centimeters per second, depending on your system. I often talk about these between meters and centimeters, and it is going to be on your system a certain way. Most modern reporting systems, it will be digital, and it will have a field that you have to put it into. And some reports that are handwritten too also have the units. Make sure that whatever units your system displays in, if you need to, make sure that's converted properly on your report, because it might be a different software, might be from a different vendor. Or the docs just wanted to see it a certain way. Just make sure that that correlates. If it's reported in centimeters per second, you put 3 to 4. That's significantly different, obviously. But make sure that that's correct on your reporting. And when I talked to my advisory committee recently, they said that's one of the things that they'd like techs generally to work on better, the students to work on better, is how to write good reports. That's huge. Okay, so that is what stenosis looks like. If there's anything else I want to say. We good? You guys have any other questions on stenosis? Different from flying W. Flying W is what?
Pulmonary hypertension.
Yeah, that's good.
That better be on the
Get
test.
one question right.
I'm pretty sure it is. Okay, so let's talk about regurgitation.
Oh, look, we're right here. That's gonna hurt.
So it's getting really messy here as we go. So let's talk about regurgitation. So first of all, terminology. So modern terminology, they're trying to go back to calling all the valves regurgitation. Regurgitation is a leaky valve. It's a backflow through the valve. Classically, or in the past, they used to call tricuspid and mitral leakiness. They used to call those tricuspid and mitral regurgitation. That's always been the case. And they used to call pulmonary and aortic as insufficiency. Why they did that, I don't know, but it seems like the modern push is to now call it all regurgitation. But I want you to know that regurgitation and insufficiency mean the same thing. Okay? I generally will probably still stick with insufficiency on my testing and stuff like that. So just know that that's the same thing if you see it on a registry or some other type of test. All right, so if I've got a leaky pulmonic valve, so the pulmonic valve typically goes down this way. I'm going to draw it shut this time. Because it's supposed to be shut. I'm getting further and further up into the muscle wall here. Okay, so valve shut should look something like this. Valve tips are pointing down into the artery. If I've got a leaky valve, what part of the cycle is this in? Systole? Oh yeah, diastole. Good. So it's a diastolic function because now valve's shut, the pressure's pushed the valve closed just like the aorta, and now I've got a little bit backflowing in through that valve because I don't have a good seal. What do I call that seal? Coaptation, so know that term. In fact, if I'm talking about a valve, and say I've got these nice long redundant leaflets, okay, there's going to be a bit of I don't want to call it tenting because that implies some pathological stuff, but I've got a bit of a peak here, and there's a significant portion that does touch of those leaflets. This area where it closes is called the zona coapta. Okay? So the zona coapta is where I've got a good seal. Okay, if that doesn't seal properly, then obviously I got leak through there. Now, the whole valve doesn't leak necessarily at one time. It's not like everywhere leaks all at the same time. It's just going to be one spot that's weak or that has some kind of a thickening to it or something like that that's causing it not to seal fully. Why do you think, because generally stating, tricuspid and pulmonary valve, or in other words, the right heart valves, tend to leak more than the left. Why do you think that might be?
There's more pressure on the outside?
Yeah, so the bigger the pressure, the more pushing back on that valve, the tighter the seal becomes. So from a physiologic standpoint, it makes sense that less pressure pushing it together just doesn't hold it as tight. So at least that's my theory behind it. So those valves tend to leak more. It's very common. In fact, my gauge on how well somebody scans versus how good a system is how well we see pulmonary insufficiency and tricuspid regurgitation. If we don't see them well, either we're not getting good enough windows or the system's not good enough to see them. Because in my opinion, everybody's got at least a trace amount that we should be able to see, okay, especially on the modern systems, which clearly ours are. All right. So zona coapta. Not sure if I've got that on this test. I know down in the future I definitely do. But zona collapse is just that area that's sealed and closed and touching. All right, so with pulmonary insufficiency, what do you expect to see on a Doppler? So if it's this way, what color would I expect to see it? So leak, during diastole, valve shut, pressure's pushing back up the chamber.
So it'd be red.
So it would be red. So this is what we call the candle flame. Think of this as the candle. Normal flow going out is going to be a blue column because it's going away from us. Remember, we never invert in echo. And I should see like a little central type of a candle flame going up in the center of that. Now, it's often going to go, depends on your angle that you see it from, but that's what it's going to look like. Just make sure that when you do your spectral Doppler, that Doppler cursor goes right parallel to that flow and through that flow. And in this case, we're going to use CW Doppler for all regurgitations. We're not going to use pulsed wave. So this case, if I took my line through that, that's a very poor Doppler angle, so what I see on my spectral is not going to be very good. I need to move my transducer so that it goes directly in line with that Doppler. So I need to move my transducer to a different location so that it's 0 degrees.
You said we use pulse wave?
CW.
Okay.
CW only for all regurgitations. Okay, so where is my baseline going to be if this is going to be below baseline? So I'm going to move my baseline near the top, but not all the way. Okay, and this is going to be during systole?
Diastole.
Diastole, good.
Continuous.
Okay. CW, so do I have an envelope or no?
No.
No.
Okay, so it's going to be spectral broadening. All right, so these are very faint waveforms. Hold on, sorry. Erase that on your page. That is totally jacked up.
I can't.
I'm just thinking of the first regurgitation I come across. I'm incorrect. Why am I incorrect on this? What direction should my jet be going? Up. Right? So baseline down. My leak is going to happen during diastole, so I've got my pulmonary wave. I'll just draw it down here. That's my normal pulmonary wave, normal flow going out. Does the leak happen? Does it have like an IVRT, IVCT, or do you think it just goes straight into a leaking? It pretty much straight leaks. If it's not coapting, it's leaking. So it's either going out or it's coming back. So that's one of the clues that you're looking at this versus an actual valve flow that's outflow, is that it starts immediately after. Now these are higher velocity, much higher velocity than the outflow is, and it's going to look sort of like this. Okay, it gets a little kick at the end, and then it goes into the next pulmonary flow. Okay, so this is my regurgitant jet, is what that looks like. So these are usually up around probably around 300 centimeters per second,
So
200 to 300.
The candle flame?
This is the candle flame, that is correct. So if I'm spectral Dopplering the candle flame with CW Doppler, this is continuous wave. That's what we're going to look like. Okay? So a mild leak looks something like this. A severe leak would look something like this. Okay? So as the severity gets worse, I get more intense waveform in this, and I get a steeper slope. Okay, so the more abnormal that is, the steeper the slope, the more intense the wave is that I see. Good? If I'm going to measure anything on this side, we measure what's called the pressure half-time. So we mark the top here. We just follow that slope, usually right to the baseline, and just measure how steep that is.
What about on the mild?
What's that?
What about in the mild one?
You would do the same. So if I was to do that slope, it would just be here. I'm just following this line.
That's called halftime what?
It's called the pressure halftime.
So would you measure it all the way to the baseline for the mild one?
Yeah, if you do. So what the pressure halftime is, so this is extrapolated to there. So sometimes it actually runs off your screen if it's mild because it's so slow. In this case, it would be here. So what pressure halftime is it's the time it takes for the pressure to drop in half. So the computer determines where that halfway point is. So that would be like my pressure halftime there. This one, pressure halftime would be, that's where it drops in half. But it's really looking at the time that it takes to do that. So the time is that x-axis there. So as you can see on a worse valve, this takes less time. Okay, so that is a pulmonary insufficiency or pulmonary regurgitation. So because it's a semi-lunar valve, just looking ahead for next quarter for the echo students, it's going to look very similar on the aortic insufficiency. So aortic and pulmonary insufficiency look similar, and then tricuspid regurgitation and mitral regurgitation look similar also. Just different velocities. Okay. Any other questions on this? We covered pulmonary stenosis and regurgitation. So what causes, do you think, stenosis to occur on a valve? So the thickening is the beginning of the process, for sure. Sometimes you could have leaflets, the commissures of the leaflets where they meet together, they fuse. So you could kind of have fused stuff like that. It could be congenital, where it never actually fully opened and it kind of grew that way.
Only 2 leaflets or like 1 leaflet?
Yeah, so it could be 2 leaflets, it could be 1 leaflet. So we could have a bicuspid, it could be a monocuspid. So those are possibilities. So that's just the way that it grows congenitally. Otherwise, a normal, what we call an acquired heart disease, is something that somebody develops over time. So they may have started out with a normal valve and eventually grows together because of disease process. So any kind of thickening, any kind of damage, scarring can cause these kinds of things. Calcifications. So we can get what we call annular calcifications, or you can get calcifications developed kind of out on the valve, and any of those things can cause stenosis. In theory, too, if I got a big ugly mass that's hanging in there, too, the mass itself could be causing a stenosis, although it's not a valvular stenosis, it just happens to be going through that area. So those are the different things that can cause stenosis. If somebody's got an ugly thickened valve and they have stenosis, they often have regurgitation also. Okay, that's not, it's not unexpected to see that. What do you think causes a regurgitation or a leak?
Papillary muscles breaking? Or no?
So papillary muscles breaking, yes, on some valves, but the pulmonary valve, does it have papillary muscles? It does not. So in the pulmonary valve, that would not cause it. But if I've got my annulus and the annulus gets stretched out, so say I've got a really big pulmonary hypertension, I got a lot of fluid backup per se in the right ventricle. If it stretches the annulus, that's going to cause a leak. If the valve obviously gets damaged, it can cause a leak. You can get different infectious processes like infective endocarditis that actually causes holes to develop in the leaflets. That's a possibility. Or the cath lab was going all hog wild and they poked holes and stuff that shouldn't be there. Stuff like that can cause leaks. Okay, it's pretty much damage and or stretching that's going to cause leaks, and or just a regular thickening process that can cause it. So various things. You do get leaflets and stuff that can structurally break sometimes. So if they do, and say the structure that's holding it in place breaks, you can get a flail leaflet that goes backwards and forwards and stuff like that. Or you get redundant leaflets where I've got extra tissue. So my leaflet's coming like this. Normally, maybe there's a lot of extra tissue and it just kind of comes like this. This is what's called a prolapse, where it kind of pushes back through that. A flail would be that it's pointing back the wrong direction. A prolapse is when it kind of sinks back to a certain point and then it opens a hole. So those are things that cause leaks. pulmonary? Good, because I am too. All right. Let's start with tricuspid valve then. So tell me about the structure of a tricuspid valve. How many leaflets?
3.
Okay. What are they?
Anterior, septal, and posterior.
Anterior, septal, and posterior. Are they all the same size?
No.
No, they are different. They're all 3 different sizes. Which one is the largest?
Anterior.
And which one is the smallest?
Septal.
Okay. Is it septal or is it posterior?
Said posterior with the twin.
Oh, posterior is in between, that's what it is. Okay, so septal, yes. So they're different sizes. Tricuspid valve is the largest valve of all our valves. So what one do you think would be most likely to leak because of its size? Tricuspid valve. The tricuspid valve, generally speaking.
Oh,
I
gotcha.
meant compared to the other, compared to the mitral and stuff like that. The tricuspid is most likely to leak. Okay, so that's the anatomy. What about the structure of the valve itself? So we'll talk about what's called a valve apparatus. That's what makes up the valve. So what does make up a valve? The leaflets. Okay, so the chordae tendineae, and what do they attach to? So the papillary muscles and the annulus. Okay, so 4 things. So annulus, the valve leaflets, chordae tendineae, and papillary muscles. That's all part of the valve apparatus. So when something goes bad with a valve, it could be any one of those features that is affected. Structure of the pulmonary valve, what does it have? So it just has the valve leaflets and the annulus. Okay, same with the aorta. All right. So let's talk about views. What views do we see these from? Pretty much all views, right? So we start off with parasternal long axis. First image? No. This is going to look similar to the pulmonary as far as the right ventricle. The right ventricle is just the top of that. But now I've got like the right atrium stuff down here, right? So it's not that tubular type of structure anymore. You may see the SVC coming into it, that kind of thing. Valve tips point up into the ventricle. Okay? So the tips, if you can see the tips, are going to give a clue as to what valve you're looking at. So parasternal long axis, that's what it looks like. What about short?
Base.
Okay, so we're looking at that base view again. Okay. That's my not so great inverted Mercedes-Benz sign there. All right, so the valve on this side is going to be on the left side of your image. That is the tricuspid valve there and there. So those are decent views. Honestly, most labs will scan the tricuspid valve and do Doppler and stuff from this view all the time. Many labs don't really do this view. Why do I have you do it? Because I'm going to make you look good. All right, if you can get a good long axis view, you can get sometimes better Dopplers here than you do here. So I like to show students to do that. Number one, it does make you look good if you can get these views and other techs can't. But sometimes you actually get better jets from that perspective. So it's important to be able to do both. I don't care if later on if you drop that view out of your protocol and don't do it, but it's a good skill to have. What's the next view that we see tricuspid valve from? So apical 4. And as we talked about last time, what do you want to do to optimize how you see that? Okay, so you want to move your transducer so that it's right over top of the right ventricular apex and in line with my tricuspid valve. That other view where I come over here is only good at looking at the walls of the right ventricle. If I go from way over there, it's going to be out of line with the jet. So if this if this valve is leaky, what direction is it going to go? And during which cycle? So when it shuts, it's supposed to prevent flow going back this way, so the jet comes back into the chamber that way, and it's blue. Okay, that's what a tricuspid jet looks like. It's going to be aliasing, turbulent, all that kind of stuff. What cycle? Systole, cardiac, ventricular systole. Good. So, optimize over top of it. How do I move on the chest to make that optimized over top of that valve? Okay, I'm going to move a little bit medial, kind of halfway between my parasternal and apical. That's going to be that modified apical 4-chamber view. How about 2-chamber? If you tip too far, you could sort of inadvertently fall onto it, but basically we Doppler from this angle. From a natural standpoint of how I interface with my windows, which one do you think has the best Doppler angle? If it's a central jet.
Didn't you just say
4-chamber view. So 4-chamber view should theoretically be our best. Our best Doppler angle. Now you can have the other views go that way, and all jets don't go centrally necessarily. They could be eccentric jets where they go off to the side. What's most important if it is off the side? So say it's an eccentric jet. We'll say it goes back this way.
You have to
The
move.
angle.
Okay, so my angle here is running through that way, which is a poor angle. So where does my transducer need to go? It needs to go over here. Good. So if that's the angle I'm pulling through there, my transducer needs to be somewhere over there to see that jet well. And if you got those, then you're going to get a really nice spectral tracing. So with the spectral tracing, what direction does this go? Above or below baseline, the flow?
Are we looking at just the little jet?
Yep.
Below.
So it's going to go below baseline, so my baseline moves where?
Up.
So the one I was drawing before is tricuspid. Okay, so that's what the jet is going to look like. If I also had my mitral or my inflow on that tricuspid inflow, there's my E and A, and then I'd have another jet. I'm drawing them that size on purpose because these flows, again, are between about 3 to 4 meters per second, especially as they get abnormal. So it's really